welcome to the EMS On Air podcast. The mission of this podcast is to keep healthcare providers safe, informed, and prepared. Today is November 23, 2020. I'm Jeff Lassers, and I'll be your host. This episode was recorded on September 21, 2020. As you are aware, Season 2 of the EMS On Air podcast has been dedicated to stroke, but today we're changing things up a bit. Today we welcome Dr. Swor, an emergency center physician at Beaumont Hospital's Royal Oak, right here in Oakland County, Michigan. For over the last 20 years or so, Dr. Swor has been a staple in the EMS community here in Michigan, especially Southeast Michigan. As long as I've known Doc, and it's been a long time, he's always been deeply involved in EMS and cardiac arrest research. He's got a pretty impressive background when it comes to EMS cardiac arrest outcome data. Data provides us with an objective look at what was supposed to happen versus what actually happened. Sometimes looking at the data from an objective perspective can reveal controversy regarding the best treatment options for cardiac arrest patients. Bottom line, what we expect regarding how things work or how well they'll work isn't always truth. In this two-part discussion, we'll discuss many of the controversies that find their way into the discussions of EMS providers and give you the hard facts, as they're currently known. Today, Dr. Swor discusses the data and related controversies regarding airway, breathing, and ventilation in regard to EMS management of cardiac arrest patients. In Part 2, we'll get into the details and data of compressions, blood flow, and circulation. Please keep emailing your questions, comments, feedback, and episode ideas to the EMS On Air podcast team by email at qi@ocmca.org. Also, check out our updated website, emsonair.com, for the latest information, podcast episodes, and other details. Follow us on Instagram at EMS On Air. And please, whatever podcast platform you use, subscribe to our podcast and leave us a rating and a review. It really does help us to grow this thing. Enjoy the podcast. Dr. Swor, how are you today?
I'm good, Jeff. How are you?
Fantastic. Can you give us an introduction of who you are, where you do it, and a little bit of your background, sir?
I've been an emergency physician at Beaumont Royal Oak since 1983, so this is my 38th year in practice. Somewhere early in my career, I got involved with EMS, actually, when I worked at Martin Place Hospital with the ALS crew there. Since then, I've been involved as part of my career working with EMS activities. Was active in the Oakland County Medical Control Authority, was the chair of the board for a period of years, and have been involved with a number of other EMS activities, including the National Association of EMS Physicians and the National Registry of EMTs. And part of my passion for this has been making good care better in the field, but also doing research in emergency medical services care. And that's kind of where I am these days.
And in that experience, you seem to have really centered around a lot of cardiac arrest care, research, and it seems to be your passion in a lot of ways. Would you say that's true?
Yeah, I guess you don't work in the emergency department for very long and realize that we don't save a lot of lives in cardiac arrest, but what happens is if people's lives are saved, they're saved in the field. So it has to happen prior to arrival in the department for people to generally, there's exceptions, but generally, if somebody's going to get resuscitated, if somebody's going to go home and pay taxes next year, it's because they got defibrillated in a gym, they got bystander CPR, got a rapid ALS response, got defibrillated, got drugs, got an airway. Typically, if somebody comes to the emergency department with a pulse, they've got about a 30% chance of leaving the hospital alive. Whereas if they come to the hospital with CPR in progress without a pulse, they've got less than a 1% chance of survival. So I realized that fairly early on. And then if I was going to make an impact, or if we're going to make an impact to the community in terms of saving lives for cardiac arrest, it's got to happen in the field. And there's a lot of literature from around the world, the country, that just bears that out. So that's where it's kind of fun, because EMS providers save lives. Pretty straightforward.
How soon in your career did you recognize the benefit of we can say early intervention, but really utilizing your resources, like you're saying, EMS. 1983, EMS wasn't exactly a 100-year traditional organization at that point. So we still had a fairly new industry. And then you recognize the need for us to do more, or at least to do well in the field to give the best chance of survival. How early in your career were you recognizing that? Was that in the early 80s, or was it a few years down the road?
Actually, it's funny because I worked for a year at Martin Place Hospital in 1980. They had an ALS crew there that would work in the department, and they would be dispatched out to call. In a word, those guys were great. They'd go bring a patient, bring it back, and you start the IV, help you manage the airways and the ED, and they talk to you for the next 2 hours, and they were very careful about, if I did something wrong, I have to face Dr. Swor or whoever for the next couple hours or until this patient goes upstairs. And there was little that they did wrong. They asked lots of questions. I never realized that they were pioneers in EMS at the time. And they'd come up and they'd bring a textbook and say, well, it says here in Harrison's textbook for internal medicine, which was the classic text of the time, that this is how you treat pulmonary edema, and you didn't do that. So right away, I learned that, one, they saved lives, and two, they were incredibly sharp and passionate about care, and it rubbed off on me. So that was actually when I started to realize the value of EMS. So a long time.
It sounds like that's what attracted you towards combining the hospital and EMS to be more interaction for the benefit of the patient.
Well, EMS isn't just ambulances and providers. EMS is really emergency medical services. They're integrated systems of care. That my vision of this has always been is that when you dial 911, you enter the healthcare system, the emergency care system. And so to the extent that that's seamless and we provide care, and the surgeons know that now, the cardiologists know that now, the stroke providers know that now, is that when everybody does better when this system works seamlessly from the time that somebody picks up a phone or grabs their cell phone until they leave the hospital. So yeah, it's a system of care and everybody has a part in it, and I have a small part in it. So it makes it fun. It's been a good career pursuit.
Well, thank you for that. When we talk about improving cardiac arrest survival, we're talking about what you're talking about, recognizing where there are deficiencies and where there's assets and creating a better system. And it seems to be that there are growing repositories around the nation and the world to collect data related to cardiac arrest survival. One is CARES, and you seem to have an integration with CARES. Can you let everybody know what that acronym stands for, as well as give us an overview of what CARES is and what they do?
Okay, CARES has been around since about 2003. CARES is a cardiac arrest registry to enhance survival. It was developed out of Emory University. They hooked up with the Center for Disease Control, which is also in Atlanta, got funding. And basically what it was a database that could match up what happens in the field when what happens in the hospital, so that we could get data on what happens in the field and how does it impact ultimate survival. And over the last 20 years, it's grown to the point that now it covers about 30% of the population of the country. The Director of the Health and Human Services has made a commitment that he wants a national cardiac arrest registry, and so they're developing funding for it. It's the bane of most EMS coordinators' existence because they got to put the data into CARES and they have to chase down follow-ups and chase down first response. And it seems like it's a lot of work, but you can't manage what you can't measure. So having a cardiac arrest database that includes both hospital and EMS elements and dispatch elements in a lot of places is just vital to improve what we do.
One of the lines I didn't come up with this, but one of the lines that somebody said to me once was, how do you inspect what you expect? And what you're identifying is that we have now a system, CARES, which allows us as a data entry point to identify this is what's supposed to happen. And now we can look at it in the field compared to what happened in the hospital, tie together strengths, weaknesses, and lessons learned objectively and learn from those experiences.
It's 30,000-foot view of how the system works. And it's one way that the EMS system saves lives. and be able to identify and document to the extent that we save lives in the community. We save hundreds of lives every year in the state of Michigan. It's invaluable to be able to document what we do, and it's invaluable to know where the holes are in the system and how we can improve.
You mentioned that there is work involved with getting the data to transfer to CARES, and we look at that as work. And I think you and I both agree that the juice is worth the squeeze. So how does the data get to CARES in order for the CARES people to categorize it?
Yeah, and the juice is worth the squeeze because it's not our juice. But so when we started this, it was all manual. Is that different EMS coordinators for different agencies. We started out in 2005, actually, doing it here at Beaumont with the CARES system, one of the first places in the state. And that was all done by hand. And there's a CARES registry. It's a web-based thing. It's de-identified once it's done so that it's HIPAA compliant. It's morphed into being able to be uploaded from ESO, different image trend, different data elements. So some of those can upload the data directly into CARES. Some of them can't. Some of them it comes and goes. But basically it has to start at the agency level where the data gets entered. It gets routed automatically to a coordinator at each hospital who will complete the data on, did the patient get hypothermia? Did the patient get cath? Was the patient made a DNR? Did the patient survive to hospital admission? Did the patient survive to hospital discharge? And did the patient leave with a good neurologic outcome? Were they able to go back to work? Were they mildly injured? Were they neurologically devastated? So all that stuff gets done on both sides of the hospital EMS divide and creates a final record.
So that really ties together what I did in the field to what happened to the patient. And a lot of times I can't control what happens to the patient. There's 50, 60, 80 years of healthcare problems or just life, how it happens when people normally expire. But in those instances when we can do something, this would reveal the trends amongst hundreds, thousands, if not even more, cardiac arrest cases that are going to reveal the strengths, weaknesses, and lessons learned of what we're supposed to do. Would that be correct?
Yeah. In Michigan, it's evolved such that we've got about 90% of state's population is covered by EMS agencies that provide data to CARES. So we get to know that through the data, and each agency and each hospital gets a summary report once a year. And I'm amazed when I talk to people how often that report goes back to city councils, hospital boards of directors, et cetera, et cetera. So people use that.
People listening, if you've never seen your CARES report for your agency as compared to your med control, your county, your state, and the nation, it's very interesting information. It is the stuff that dives into, was the patient released from the hospital neurologically intact? Or to what degree? And where is your agency in demographics compared to other agencies and where they respond? And then how do you compare and what are they doing different than you if they're doing better?
Right. No question.
So that's what we do with the data. We learn from it. We collect it, we compare it, and in Michigan, that's 90% of our agencies covered. So it's giving us an honest look at our state. And I'm sure we're not the only state doing that. There's a lot of other very good states diving into probably more than 90%. But there's this other organization called Save My Heart. Can you compare and contrast CARES to Save My Heart?
Save My Heart was developed by a group of medical control authorities and academic medical centers. Started out with University of Michigan, Beaumont, Wayne State University, and now Henry Ford that have sponsored the development of this organization whose job in 2013 was to double cardiac arrest survival in Michigan by 2020. Well, in 2013, that sounded like such a great idea, and it still remains a good idea, but we didn't get there by 2020. But our goal is to continuously improve cardiac arrest survival in Michigan. Organizations don't save lives or do things, people save lives. So we hired Terry Shields, who's the executive director and CARES coordinator of Save My Heart. So the foundation of Save My Heart is the CARES register. So the thing that Terry does is that she coordinates with all the EMS agencies in the hospitals. So she's got a fair amount of gray hair and all a big job to make sure all this gets done and gets the data for the state of Michigan, Michigan CARES. So CARES is foundational to Save My Heart. Any of you that have collected data for anything realize that it's such an exhausting process that you almost don't have time and energy to do anything with it by the time you've completed the process. So what happens is that the Save My Heart group tees that up for us. Terry, and she has other staff that work with her periodically, collects that data, organizes the data, generates the reports, assures the data's clean, and does that and gets the data to users of the reports. So what we've done with that is we've been able to get some money to support CPR training initiatives, hospital research projects, academic medical center research projects, initiatives in medical control authorities around the state, all of which that are intended to improve cardiac arrest survival, and probably can't do it without CARES data. So we have a board of directors, we have an advisory committee, there are subcommittees that address dispatch, community-based care, so bystander CPR rates, post-hospital care, and I think that's it. All of those groups focus on how do we improve rates of bystander CPR, bystander automatic defibrillation, dispatch CPR provision, and lately we focused a little more energy on how do we get the hospitals to get more aggressive with patients that are resuscitated in the field and improve survival in the hospital. So 9.8 million people in the state of Michigan. You can imagine it's a big initiative, and it all starts with people. And Terry and the group from Save My Heart uses the CARES data as the foundation to improve cardiac arrest survival.
That makes sense. You got CARES acting as a repository to say, here's the data, no opinion, here's what it is. And then you're the group of Save My Heart, and that's MI for Michigan, not MY. But Save My Heart is taking that data and saying, okay, based on the conditions within Michigan and all of its agencies, what do we do with it? Which is probably different than what, Ohio or Kentucky or Indiana needs to do with it, because their numbers and conditions are different.
Right. But interestingly enough, it's a model for other states, and a number of states have had statewide initiatives to improve cardiac arrest survival. Michigan's the first that we've done it as a consortium of medical centers and medical control authorities. And Ohio actually developed their system similar to ours based on the Save My Heart initiative. But it's a good model. It works to greater or lesser degrees. It's like anything. If you had more money and more staff to do different things, we could focus more efforts on this. But we've developed a dispatch CPR course. We've developed an online dispatch CPR course. The city of Detroit was able to get some foundation money to develop focused training for bystanders on CPR. And Michigan has got a couple initiatives at Washtenaw County and Livingston County that are focused on what they call learning healthcare systems that are based in the community to improve care. So lots going on, and Save My Heart supports all that. So it's a great initiative.
Well, it sounds like CARES is at least fueling these things to exist. And anybody working on the improvement of cardiac arrest survival is cool in my book and is helping. It probably feels like you're beating against a wall sometimes when it comes to cardiac arrest, because at the end of the day, there's only so much you can do. And it's not exactly the easiest healthcare crisis to identify the trends and fix, because we have things that we expect how they work, and then we have the data that shows how it actually worked. And that's a big reason why you're here today, is to talk about some of this controversy in cardiac arrest. So data, or CARES, provides us with an objective look at what is supposed to happen versus what actually happens. And sometimes looking at the data from an objective perspective can reveal controversy regarding the best, quote unquote, best treatment options for cardiac arrest patients. So bottom line, what we expect regarding how things work or how well they work isn't always truth. So let's discuss some of these controversies that find our way into the discussions of EMS providers, and let's talk about the hard facts. First, let's start with airway and breathing. Advanced airways versus basic airways. When I was coming up through EMS, and you were the physician medical director of my paramedic school at the Oakland County Community College, in that time, it was made very clear to me by my instructors and through my experience that ET intubation was very important for me to learn how to do at a very very high level. And we seemed to be putting a lot of onus on ET intubation during cardiac arrest back in those days, nearly 20 years ago. Where is the data on ET intubation for cardiac arrest patients versus maybe more basic or supraglottic airway devices?
So thanks for that. And your observation, and that's what I always remember is going to OCC and practicing paramedic students, the paramedic students always parroting that endotracheal intubation is the gold standard airway. It's the best airway, et cetera. Well, so I think what we've come to appreciate over the years is that the goal isn't to get a tube in the trachea so that we can blow it up. And that's, our high five to do that. The goal is to optimally oxygenate and ventilate a patient in a timely fashion to control the airway to improve survival. So somewhere along the way, we got focused on endotracheal intubation, and there were long pauses, and, somebody would get off the chest, take 45 seconds, 60 seconds, et cetera, to place a tube in the trachea, and that didn't improve outcomes. So there was a lot of observational data early in 2000s that identified that, well, maybe intubation was not only not the best airway, but maybe it was the way we practiced it in the field was something that adversely impacted patient survival. So people were off the chest, cardiac compressions weren't done, delays to defibrillation were done, et cetera, et cetera. So since probably about 2005, the Heart Association and the scientific literature has identified that we should be more focused on CAB, circulation, airway, and breathing versus airway, breathing, and circulation. And airway intubation through endotracheal intubation wasn't the key priority at cardiac arrest. So that's the history behind it, and that's kind of where we all grew up with. So now the question is, well, what is the best airway? And I think I have to tell you that I'm not sure we know the best airway yet, and that what we know is that delays to intubation are bad. Intubation in the esophagus is bad. Supraglottic airways, King airways, combi tubes, esophageal obturator airways back in the day, eye gels, etc., have a role in ventilating an oxygenated person during cardiac arrest. And what is the best way to do this? So that's all been the controversy probably over the last few years.
So when I face this in the field, I go back to what you just said. The goal. What is the mission when I'm dealing with the patient's airway? And what you're saying is it's optimal ventilation and oxygenation. It's not intubation. It's not a SAD device. It's optimal. So to me, that says, what is the patient, age, position, morbidities? What are all the things going on to select one of my tools? One of those tools once in a while might be ET intubation. More often than not, I'm going directly to OPAs and supraglottic airway devices, eye gels, King airways. But I think it's really important for us to highlight, yes, the data is not conclusive on what is the best device, but what is conclusive is that optimal ventilation and oxygenation is something that's very important, but it also is prioritized after compressions and circulation.
Yeah, it's very interesting because there's been so much interest in this that probably 2 years ago, there were 3 large studies comparing should we intubate or should we use a supraglottic airway? And I'll go through those in a little bit of detail. But also the question still isn't answered. There's one provocative study out of Arizona a few years back where they just put a non-rebreather mask on patients in cardiac arrest, and they had a better outcome. Well, we started doing that in COVID a little bit. But, that's the sort of study where you look at things when it happens, after the fact. So nobody's actually randomized no airway versus airway in cardiac arrest. So while there's some data that suggests that might be the best approach, and I'll talk about why in a bit, but mostly people have looked at what's the best airway. So there were 3 large studies, one in the US, one in England, and one in Paris, and they all looked at different things. The one in the US was done at 10 centers, what's called the ROCK Consortium, and they compared using the King airway to endotracheal intubation and looked at outcome of survival for out-of-hospital cardiac arrest, both survival to discharge and survival with good neurologic outcome. And so it was about a 3-year study, 10 big places. And what they looked at is the strategy of, on these days, we would just intubate, and on these days, we would just put a king airway in the first airway. So what they found is that there was a mild but significant improvement in patients that got king airways. So that was a little surprising and maybe counterintuitive to a lot of us. But there was a little bit of an improvement to king airway versus endotracheal intubation. That gets complicated because on an intubation day, you failed intubation, you put a king in. If you put a king in and it failed, then you pull it out and put an endotracheal tube. So the way you manage the statistics of this are complicated. But the bottom line is that king airways were mildly better. One of the observations that was surprising is the intubation success rate, first pass intubation success rate for endotracheal intubation was 50%. 50%. So half the time people weren't successfully intubated.
Well, that tells me that the king's better just from that, because with a king going in, it's probably a lot higher than 50%. So just on that, it just anecdotally feels like king's already better to me, no?
Right. But there's been so much literature over the last few years that I think paramedics have come to realize that, I shouldn't spend a lot of time doing this, and I should quickly abort if I'm having trouble. That's clearly been drummed into people's heads. So that study probably is going to drive practice in the U.S. to a large degree. The results weren't overwhelming, but they were statistically significant, and they showed that patients that received supraglottic airways did better than endotracheal tube. The Airway 2 trial in England was amazing. It was 4 times the size of this U.S. study, and they randomized patients to either by the paramedic. So a paramedic would intubate or use a iGel, and they randomized the paramedics as to who would get which device or which approach. And there was no difference in survival between iGels and endotracheal tubes in England. It was 4 times the size of the U.S. study. It covered 40% of the UK population. So huge study, really well done. There were some certain subgroups that did better with just the iGel. But basically the conclusion is there wasn't a difference between the two airways.
Is it possible to elucidate that their providers are more practiced with ET intubation than what we studied here?
I haven't seen data that compares what the training is of paramedics in the UK versus training in US paramedics. I do think that they get paid better. And so there's more longevity. So, your good paramedics don't grow up to go to med school or go to nursing school, et cetera, et cetera. They stay in the system. So there is some systematic differences. But for this study, I don't think that was the key difference.
What about, you said on the other one, it was a 50% success rate with putting an ET. Did they measure the same thing for the ET intubation in this case?
They did. And I don't recall what it was, but it was better. I do recall it was better. So interesting study, very provocative, was done just about the same time. I think it actually was published in the same issue of JAMA, the Journal of American Medical Association, as the U.S. part airway trial. Both of those come up with, in the U.S., maybe the King's a little bit better than the ET tube. In the U.K., iGel was not different than U.S. So it gives you a bunch of different options as to what the circumstances are and what's the best airway to use. So then the question, of course, is, should we not intubate at all? Should we just use bag valve mask ventilation? And the French did a study that they compared intubation to bag valve mask ventilation, which is really interesting. It's like, maybe we shouldn't intubate at all. Maybe we should just bag because that's probably easier, right? Well, turns out that's not the case. And the French use EMS physicians that are not interns, physicians that are specifically focused on providing care in the field. And so what would happen is that the patients would be randomized to either endotracheal intubation or bag valve mask ventilation, and that they look to survival to outcome. Now, as you can imagine, there aren't as many physicians that are providing care as there are paramedics. So there were fewer docs. Their response times were longer. The EMS system is such that there's first responders that would all bag valve mask all of those patients. So all patients would get bagged initially until arrival of the ALS crew, the physician crew, and then they'd either randomize them to intubate or bag valve mask. Interestingly enough, there wasn't a difference in survival. Interestingly enough, there were more complications in the bag valve mask group, especially aspiration. So not a surprise to anybody that's been on scene and bagged a patient with a bunch of schmutz in their airway and trying to figure out how to best manage. And there were a certain percentage of patients that the rate of ventilation failure was high, a little bit higher, not tremendously failure. They were higher in the bag valve mask group. So what you learned is we got to intubation because bag valve mask isn't so easy sometimes. A lot of times it's straightforward, simple. You can ventilate patients. A lot of times, depending on the size of the patient, the circumstance, the location, bagging the patient is just harder. So where we are with all this is that airways work. Intubation isn't necessarily better than no intubation. And in fact, it may be better to intubate somebody or place an advanced airway than to just do bag valve mask ventilation. And there's different options for managing an airway, whether it's a supraglottic King airway or iGel. So that's pretty much where we are. And Jeff, you left a question out here is the rate of intubation increasing, decreasing, or staying the same over the last 10 years? I haven't seen that data, but I'm pretty confident that most places are using supraglottic airways as their first pass airway. And it would be interesting to see what's the national trend or the state trend or even the county trends in terms of how many patients are intubated versus have supraglottic airways.
That certainly would be interesting information because it does feel in my practice that we're pulling the ET kit out less and less. We transitioned to the King Visions, which allow us to be a little bit more accurate with our ET intubations with, it's a mini glide scope essentially. So that made it a lot easier. But then when we transitioned to COVID, we got away from all intubations. So I'm way out of practice with ET intubations. It's been a good solid 6 months.
Right. It would be interesting do you have data? Does the county have data on this? It would be interesting to know.
We're going to start pulling it because you're sparking up a lot of ideas in my mind. I'm going to pull some data and see if we can also work with CARES to see if there's a national data we can pull as well.
Yeah. Interesting stuff.
I do have one follow-up question to your Paris fellas there, and I'm sure that the answer is yes, but I'm assuming they did utilize OPAs and or NPAs in this situations.
I would believe so, but I don't know that.
Okay, they didn't spell it out, but the standard of care typically would say that they did.
Exactly right.
All right. I do want to point out the iGel versus the King Airway, and I haven't used the iGel a lot. I've recently been introduced to it in the last year. My agency is starting to look at them more and more. I like them a lot. What is your thought on the iGel versus the King? In my opinion, don't tell King, but I think the iGel is pretty cool.
Well, it all boils down to money.
Oh my God. Really? Are you sure?
No, the places that I've heard use the iGel have been pleased with it. It's easier, blow up the seal around the larynx, and that's about it. It seats in the airway pretty well, and they've done different versions of it to stabilize it. So, the experience I have with the iGel is it seems to work very nicely.
Yeah, they look cool, they feel good, but at King Airway, anybody working at King, we still like your stuff too, don't worry. But let's talk about ventilating. So no matter what we're utilizing, it's becoming more and more commonplace that our providers are understanding what proper ventilation looks like. My entire career has been a roller coaster ride of when to hyperventilate, then we ventilate too much, we ventilate too little, force versus pressure, So what is the most obvious problem we're seeing with ventilating cardiac arrest patients?
So it's interesting. This is that those of you that have been in the field for a while know that when you get on scene and there's somebody there, they're jacked. They're putting the BVM on and they're nervous as heck and they're bagging forcefully. And it's a matter of some honor as to tilting somebody's head back, putting the mask on, putting the airway, the bag on, and then crushing it against your thigh. That's what we used to see in the day. And the person that ventilates classically in cardiac arrest has been the least trained person or the least experienced person, at least initially, until the airway gets placed. So that's been something that was observed. There was a study done in the early 2000s where they noticed that some docs from Milwaukee were doing a cardiac arrest device trial, they would respond to the scene and they'd actually put in arterial lines in the field to measure blood pressure. They noticed that when they measured the ventilation rates, the patients that were getting ventilated 24, 30 times a minute. And the faster somebody was ventilated, the worse the survival rates of those patients. So they went back to the pig lab, actually, and they randomized the trial to a cardiac output based on ventilatory rate. And they showed that the faster you ventilate somebody, the lower the cardiac output and the worse the survival. And that makes sense because basically it's all about blood flow. And when you ventilate someone faster and you ventilate someone with a larger volume, you increase the pressure, the interthoracic pressure in the chest. You decrease blood flow back to the heart. You decrease cardiac output on the next forward. And then obviously decreasing cardiac output is a bad thing for resuscitating hearts and resuscitating brains. And that's true for a number of entities. When somebody's in shock, when somebody's hypovolemic, you intubate them, you give them positive pressure ventilation. First thing that goes is their blood pressure dumps. So the Heart Association standards have changed. So the ventilatory rates are now 10 to 12. Ventilatory rates, for kids are less. So less ventilation is better in terms of ventilatory rates for cardiac arrest. Now, that's easy to measure. You can measure how fast somebody ventilates. You can also do things to control them. We did the rescue trial a number of years ago. One of the more valuable parts of the rescue trial was it had a little light that timed how fast you would ventilate. So ventilatory rate is pretty easy to measure and it's pretty easy to correct. What's harder to measure and what's harder to correct is ventilatory volume. And as we talked about, ventilatory volume is dependent on how geeked up the person is, how well they're experienced they are, etc. And so there's a group at Washington University, which is in St. Louis, who was able to use a simulator to measure ventilatory volume. And that was helpful. So what they did is they started out with the hypothesis of, should we use adult bags or should we use kid bags to ventilate adults in cardiac arrest? What they did is they took a group of medics and then they had them ventilate mannequins in a simulation lab, which was hooked up to a device that would measure ventilatory volume. And they identified the mannequin as your average 70 kilogram male. And they estimated that the right ventilatory volume, the standards for the right ventilatory volume is about 6 to 8 cc's per kilogram. So that's not a lot of volume, but 6 times 70 is 420 cc's. So between 420 cc's and 640 cc's. And a bag valve mass in adult BVM is 750 to 1,000 cc's, I think is the right tidal volume. And so what they did is they had the medics do a simulated CPR with an adult bag and with a pediatric bag, not an infant, a pediatric bag. And they identified that adult mannequins that were ventilated with an adult bag were overventilated in about 95% of the cases. Pediatric bags even overventilated the mannequins in about 80% of the patients, but also hardly ever underventilated the patient with a pediatric bag. So in other words, a pediatric bag provides enough volume, probably still overventilates the patient, but doesn't underventilate the patient in hardly 2% of the cases. So that's sort of provocative. It's like, should we be using a pediatric bag? Should we be teaching medics to just use 2 fingers for adult bags? Should the medic's key role be to make sure whoever's at the head of the airway doesn't overventilate the patient? I think the answer is yes to all that. So it's just somewhat provocative and goes back to the other literature on airway is that all these studies looked a lot at which device they were using, but they didn't look at how the patient was ventilated. So maybe the problem with all of our advanced airways, ET tube or even supraglottic airway, isn't that they're the wrong tube. It's just they allow medics and docs and providers to optimally overventilate the patient. So the bottom line on this may be is that when way back in the day when there was parchment for EMS books and Jeff was in program, that maybe that tracheal intubation was the optimal airway to best manage a patient's airway. Maybe endotracheal intubation is a nice, clear device that maximally allows us to overventilate a patient. And that's why studies looking at endotracheal intubation have worse outcomes. Maybe it's just easier to hyperventilate somebody and increase their ventilatory volume.
Less resistance. When I squeeze that bag and I got a direct shot with a nice clean tube, it's
Right.
really easy to squeeze the hell out of that bag.
Right. I mean, the way supraglottic airways are designed is you're going to fill up the hypopharynx and then it subsequently goes into the lungs.
Yeah, I got to overcome that little pocket to get it into the lungs, right? So there's just more resistance, physics imply there, versus I have a nice rigid tube down inside a nice rigid tube that I'm filling up 2 big bags of air.
Right. So it's really provocative and really interesting that what we should do is that I think the answer to part 1 of this is that managing an airway is to give patients oxygen, ventilate them adequately, make sure they don't aspirate, but not do that at the expense of getting good cardiac compression. And that ventilation needs to be the key thing that we're paying attention to. Smaller tidal volumes, slow rates, 10 to 12 for an adult. And the person that's doing the ventilating needs to realize that they're not the forgotten man or woman at the head of the table. They're the key driver of cardiac output for a patient. So can we prove that? Probably not. That's all. It's really difficult to figure out in the field how much tidal volume you get.
Yeah, totally. It seems to make total sense, but it also makes total sense that going to the physics of the inside of the chest cavity, the literal positive or negative pressure within that chest has so much to do with cardiac output. It's almost as important as how good you're forcing the chest, because I could produce really good compressions. But if that chest cavity is full of a positive pressure, that balloon, that's my 2-year-old.
Yeah, it's good.
But when you have, excuse me 1 second. I lost my train of thought.
Yeah. You're pushing it. If you've got positive pressure ventilation, you're pushing air up into the internal jugular and down into the inferior vena cava, and you're squeezing it out of the chest where it's not filling the heart, where it's not getting pushed forward by the next cardiac compression.
Yeah, we're like fighting each other. You got one guy pumping on the chest, forcing blood out, and then you got another guy filling up the bag inside the chest, almost slowing down the process. And what we're highlighting here is the tools that control the airway aren't necessarily the problem. It's the person squeezing the bag and controlling the airway, which may be providing the problem.
Right.
So that brings us to our second episode that you and I are going to do in the next week or so, which gets more into the compression side. But the link between the two is this little device I want to touch on before we go, called an impedance threshold device. This is a really cool device. You talked about the timing lights on it, which are very beneficial. Every time it blinks, you squeeze the bag appropriately. But what it is, it's a one-way valve that lets air escape. So I can still ventilate the patient. It doesn't block it. But the chest will turn into a vacuum, which will increase the ability of the heart to suck blood in, preload, to create cardiac output, right? So give us your take on these ITDs.
The long version is that we were involved in a study with 5 other centers that looked at the ITD and then the compression-decompression device. I'm pretty familiar with the device and spent a little bit of time with it. And it's conceptually fascinating, is that it makes sense. Keith Lurie, the guy that invented this, was talking to a respiratory therapist in the hospital, and patient's intubated, they're doing CPR, the respiratory therapist puts his thumb over the endotracheal tube, and you get this inspiration, this sucking in sound that you would think that you would get if you're not letting air out, you're just putting a thumb over the endotracheal tube. So it caused a negative intrathoracic pressure, which is what you do when you expand your chest. You get the same air, more volume, so less pressure, so it's negative. So that improves venous return from the lower extremities, from the rest of the body. So that's the concept behind that. It's also interesting is that there's some veins in the spinal canal that are decreased as well. So it sucks blood from the brain back into the lumbar plexus and decreases intracranial pressure. There's some theory that does that. So it sounds like the right thing to do. The impedance threshold device is a cool thing. It fits on a supraglottic airway or it fits on an endotracheal tube. There's a lot of literature in the lab that shows that it decreases interthoracic pressure and is associated with improved cardiac outcome. Unfortunately, in the largest study that was done nationally, where devices were randomized to whether the impedance threshold device or a device that looked like the impedance threshold device that had a timing light, but didn't have the valve in it to cause suction, and it didn't show any improvement in survival at all. So it's what the researchers call a beautiful hypothesis slain by an ugly fact, is that this one big study, and like any study, there's limitations to it, the time to get the device on, et cetera, et cetera. So in our hands, in the rescue trial that we did, as part of a system of care, using the rescue pod and the pump, the ITD improved survival. There was a slight but real improved outcome in patients that got both devices. But in the large trial, I can't remember the name of the specific trial.
Was that the rescue trial?
Well, the rescue trial was the study that we were involved in.
Yeah.
The Rock Prime study, where they looked at the ITD versus the sham ITD, didn't show an improved outcome. So a lot of places are still using the ITD, but a lot of places said, this is $80 a pop. We're not going to pay for this in the setting of cardiac arrest. So the ITD is a great concept. It works well in the lab. They're using something like it for low flow states like patients in hypovolemic shock because it increases venous return and cardiac output. But it isn't what I would call standard of care in the treatment of hospital cardiac arrest.
Yeah, I totally agree with you. It doesn't seem to be becoming the standard of care, but man, when I heard about it and I understood the simple science behind it, it just made sense to me. And I was actually surprised that the numbers weren't more impactful. But you're saying there is a real measurable difference in certain situations. And maybe over time, with the increased use of it, increased availability of it, we may be able to study the benefits of it and apply those to other situations as well.
Yeah, and the Rock Prime study was a big network of out-of-body cardiac arrest research studies. It was the same group that did the ET versus King Airway study. So it was a big nationally funded NIH multi-center network that was designed to do stuff. I don't think you're going to see another big study like that anytime soon. So you're stuck with, there isn't overwhelming data proving benefit, and there's some smaller studies that are out-of-rider studies, and conceptually seems to make sense that it would work, right?
Totally. It just, the way you look at it, and then you literally can take a container, stick a balloon inside of it, turn it into a vacuum inside of there, and you watch it expand. It's like, there's preload. It doesn't make sense that it doesn't work to me. So there's obviously things we still need to learn.
Well, there's efficacy and effect. There's device, and they're not paying attention to other things they need to be doing. If they're slow in getting it on, if it gets clogged, all of the real life things that get in the way of trying any new intervention. But it's conceptually, it's a cool thing. It's conceptually things that a number of different communities continue to use and results in, physiologically makes sense.
Totally makes sense. And I think it's a great topic to pick back up on in our next episode, where we transition to the use of maybe that with mechanical CPR, active compression, decompression CPR, and compressions in general. We'll get into circulation in the next episode. We wanted to focus more on airway, breathing, ventilation in this one, and we'll continue on with cardiac arrest controversies with Dr. Swor in another episode coming up soon. Dr. Swor, do you have any closing comments for us today, sir?
Thanks for the opportunity to do this. It's interesting how far we've evolved and how far we still have to go with cardiac arrest care.
Absolutely. And no matter what we learn, I think we're going to learn something new, and we'll just find another mountain to climb. And I think that's kind of the point.
It is.
All right, sir. You have a great day.
All right. Nice talking with you, Jeff. Take care.
All right, buddy. See ya. That is all for the show today, everybody, and thank you very much to Dr. Robert Swor for joining us today. He'll be back, everyone. Remember, we have a part 2 where we're going to get into circulation, compressions, and blood flow and the related data, brought to you by Dr. Swor. Thank you for listening. Please keep emailing your questions, comments, feedback, and episode ideas to the EMS On Air podcast team by email at qi@ocmca.org. Also, check out our updated website, emsonair.com, for the latest information, podcast episodes, and other details. Follow us on Instagram at EMS On Air. And please, whatever podcast platform you use, subscribe to our podcast and leave us a rating and a review, because it does help. Thank you for listening to the EMS On Air podcast. Stay safe and have a great day.